waiter's tip. And there was a lesion from a waiter's tip. What happened? And what does that mean? When I say waiter's tip, what is that? What is happening? The arm is in what position? Extension? Yep. And then what reflex do they still have? The grasp. And what happened most likely? Shoulder dystocia, and what nerves are affected? C5 and 6. So what other system might be involved? Respiratory. Yep. You're trying to prevent spina bifida. What supplement do you need? Folate. What trimester? First, all of them, and before. So anyone childbearing age. Yep. Okay, a neonate has sepsis. You think this neonate has sepsis. They are 6 days old. What is your empiric antibiotic treatment of choice? Ampicillin, heard it, and gentamicin. Okay, same baby has a twin, and that twin comes in and you think they're septic and they are now 27 days old. What do you treat that 27-day-old with? Ampicillin. Yes, cefotaxime. Cefotaxime. Our little babies are little tax breaks, so it's cefotaxime. What is the diagnosis if I told you that on x-ray there was diffused ground glass appearance? Not ARDS, but close. With just loss of surfactant, or no surfactant, yep. Or meconium, but meconium's what looks like what on a chest x-ray? Patchy. Yep, it's a patchy ground glass. Yep, respiratory distress syndrome, RDS. So close to ARDS. We haven't done that one yet. Okay. Let's do some of this. So today we get to talk about one of my very favorite topics. And I know I'm going to say that a lot, but this is truly one of my absolute favorite topics. Meaning, I'm telling you right now that there's one objective on it, but when there's only 42 for this block, I think, so there's going to be a couple questions on this one, okay? So a couple of questions about all things bilirubin for babies. And the reason it's why is because this is something that is common to all babies, and this can kill babies. And I don't want us to kill babies, because remember my goals were pass your pants and be safe and competent PAs. So anything that's going to kill a baby, I want to make sure that you guys know. So you probably have had bilirubin things in all 4 semesters, and you're like, oh my god, here we go again. Yes, because this time it is particularly about the babies. So let's start with this. When we're talking about hyperbilirubinemia, all the parts of the word, so high bilirubin in the blood, that is hyperbilirubinemia. What does that cause on exam? On exam, that's jaundice. So you will see people that will use those interchangeably. One is the lab finding and where it is. One is what it looks like on exam. Okay? So just one of those things to use appropriate vernacular. A reminder that when we have bilirubin, it is because we had a red blood cell. That red blood cell lysed, that or has broken down from it being 120 days old. You have the byproduct of heme. Heme breaks down into bilirubin, and that whole cascade from Dr. Johnson of biliverdin and all of the different things that eventually get down into urobilinogen to make your pee yellow, and stercobilinogen that makes your poop brown. Okay? That is the metabolism of bilirubin. Well, we've already also said that birth is rough. So we've said Erb's Duchenne or Klumpke's palsy or shoulder dystocia. Birth is really rough. So there's a lot of bruising that goes on. There's a lot of kind of manhandling these babies to get them out safely. And so babies have an increased level of red blood cell breakdown. All babies going through a C-section or vaginal birth. The other part is that they all have that nadir that we talked about yesterday, where they lose some of their hemoglobin just because they are now born, and that dip that happens naturally. At the same time, the organ that handles all of that hadn't been in use for 9 months. Remember, feet had been kicked up. The liver that is dealing with all of this isn't turned on at all yet. And so not only do we have more to process, we have an organ that isn't ready and isn't turned on yet, and then the way that it is excreted The gut isn't really moving yet because it hasn't been used in utero either. They were getting all of their nutrition from the placenta and from the umbilical cord. So you can see how it's a bad situation for these babies and why truly every single baby has an elevated bilirubin. It doesn't mean that it is pathologic, it just means it's high. So if I were to take a sample from you, all of you in this room would probably be 0.8, 0.2, 0.3. This baby right here is probably 12, 15, something like that. So every single baby is going to be high. Most common reason, you have to pick the most common reason that this occurs is from ADO incompatibility between mom and baby. So all the other things are part of the process that happens to all babies, but the reason it tips us from that's normal for every baby to be high to abnormal is that ADO incompatibility. So we're breaking that down even further. When we get a bilirubin, that bilirubin is made up of our two different things. It's made up of the bilirubin that is waiting in line, circulating round and round and round in the blood to be acted on by the liver, or the indirect bilirubin, also called unconjugated because it has not been conjugated yet by the liver. So once it goes into the liver and it is picked up and a glucuronal subgroup is put on it, that's what conjugation is. So once it gets that, the point of that is to take it from being indirect in the blood where it is lipid soluble to making it conjugated, making it water soluble, where they can then go into the bile, go into the gut, and be excreted out. Okay? So if you don't have that conjugation, we are stuck in this indefinite loop. So that total bilirubin has both your indirect and your direct. Which one do you think there's more of? More circulating or more that's acted upon by the liver? Circulating, a lot more. So there's a lot more indirect. Exactly. How do we measure that when it's going round and round and round in the blood? A couple of ways. We can either use this little fancy tool up in the very tippity top corner that takes a measurement from their skin, through their skin. So you don't have to poke them, you don't have to do anything. That is called a transcutaneous bilirubin level. You can also take blood samples, and that is going to be a serum bilirubin level. And when you do that, your totals that will come back to you as the provider, you will get a total bilirubin, and you will get the direct bilirubin. So that total has both. The direct is just teeny tiny, or should be, and you have to then calculate what the indirect will be. You will never get a calculated indirect for you. Okay, so now we've said different types of these hyperbilirubinemia. I could have it, and most likely it's going to be unconjugated or indirect. And so we can have that level that's physiologic of what we expect for every single baby, or it can reach the level where things are falling off. Too excited about bilirubin? And it becomes a pathologic level. So we'll talk about how to determine that because it is not one specific point in time. You are following a specific graph. This is all pre-hepatic, so it hasn't been acted upon by the liver. So anything to do with unconjugated bilirubin, either physiologic, normal, or it's way too high and this is dangerous. If it's all unconjugated or indirect, it's all pre-hepatic. It's floating just round and round and round. Once we get to the conjugated, we said now the liver has acted upon it or it's tried to act upon it. It's a very small amount, it's very rare, very serious. So I know it's either at the hepatic level or it's post-hepatic, meaning I'm conjugated, but there's no biliary tree. I can't get out into the gut to be excreted. So that's the most common cause. So we said there's some of these factors. So when I said the liver is not turned on and working yet, what do I actually mean by that? Well, the enzyme that actually takes the glucuronal group and attaches it to that bilirubin, that enzyme is not in sufficient quantities yet. So the enzyme, I'm not going to test you on it. It is just for you to be aware of uryl diuryl phosphate glucuronoltransferase isn't in sufficient numbers yet. So that enzyme isn't there. So we don't have that. We don't have the intestinal bacteria yet because that gut hasn't moved. We don't have the gut moving to excrete it, and then we have that increase in red blood cells. Other considerations, depending on where you are going to be for the Army or the Air Force or the Navy. What's your altitude? So if you're going to be working in Colorado, that's an additional risk factor than if you are in South Florida. Additional risk factor is altitude is a huge consideration. Is a dehydrating effect. Certain races, so Asian and Mediterranean races, have an additional factor. Prematurity is the answer to everything for what's an additional factor. Their liver makes even less of that enzyme. Their gut is moving even slower, and they have additional heme breakdown. So prematurity is a big issue. And then we'll talk about why is breastfeeding an issue. So you think breastfeeding should be good, right? Why is breastfeeding an issue? So for this, I'm going to ask you about breastfeeding versus breast milk jaundice. And people always mess this one up. So what I need you to do basically is see the words breastfeeding jaundice and then cross out the word breast. And think of it as this is a feeding jaundice. This is a problem with functional dehydration. So when baby is born, mom has been pregnant for 9 months, baby is born, it is not an immediate, my body's not pregnant and I have flowing milk. That takes several days for the milk ducts to fill and for a baby to have appropriate amounts of volume. So for those first couple of days, the baby is in a functional dehydrated status. Now yes, mom will make colostrum that is really high in glucose to keep baby's glucose up, but it is a functional dehydration, and that allows the gut to slow down even further, which exacerbates this problem. So if you have particularly a first-time breastfeeding mom and a baby who is losing significant amount of weight, they are probably suffering from breastfeeding jaundice or just feeding jaundice. A couple of days, in those first 2 to 3 days, once mom's milk comes into supply, we are good to go. Another thing that we can do is give some formula for the baby. The formula helps with more volume, helps the gut to move, helps them be more functionally hydrated, and the feeding jaundice goes away. Contrast that with not breastfeeding jaundice, but breast milk jaundice. So again, you read the word, then cross out the word breast. This is milk jaundice. So what happens in this, mom can make a ton of milk. She could be a dairy cow and be making just gallons of this stuff, but inside the milk, there is an inhibitor that unconjugates what has been conjugated. So the liver did its thing and took it and made it from a lipid soluble into a water soluble compound, goes into the gut with the milk, and there's an inhibitor that unconjugates it and puts it back in circulation. Now it does it in small amounts, so the liver is still able to compensate for that, but the baby continues to be pretty yellow. And we follow that. And so mom, you'll see this baby that is gaining weight. The baby is doing well, thriving, meeting all of their developmental milestones that they need to be doing, and continues to be yellow. It's from this inhibitor. That is from the milk itself. So you don't see that in the first couple of days. You see that several weeks down the road, 2, 3, 4+ weeks down the road. This is not going to get into a level where we need to do anything other than continue to monitor and watch. So typically those levels are less than 20. I'm not going to ask you that specific number. And it takes several months to resolve, really often until they're really eating solid foods at that point. So please know the difference between a breastfeeding jaundice and a breast milk jaundice. Okay, but when do we get pathologic? So both of those pretty much functionally were fine. So when do we say this isn't fine anymore? Because it's the same baby, it's the same process, it's the same hyperbilirubinemia, so when is it not fine? When does it become pathologic? So it's looking for patterns. So the patterns that we start looking at are, number one, is it happening really early? So jaundice in those first 24 hours, I don't expect it normally to get that high that fast. So if I have a baby who's 18 hours old and looking like a yellow highlighter, I know something isn't right. So jaundice in the first 24 hours, always going to be pathologic. Things that might make me think that and be prepared for that. Was there significant hemorrhage with birth? So was there a ton of blood loss or a ton of bruising? Do I already know there's ABO incompatibility and there's going to be some additional lysis there? Is the baby septic? Did mom have an infection while she was delivering and now baby has come out septic? Other considerations that aren't as a parent like that are hemolytic, so the non-hemolytic causes. Is there something underlying genetic that is causing this, that immediately their body cannot handle this? Such as Gilbert's or a Crigler-Najjar, where they don't make any of the conjugating enzyme? Or is it hypothyroidism? Because that could be the differential for literally anything in pediatrics. And why do I care? Why do I care if bilirubin is sky high? Who cares? Why does that matter at all? Well, we said that indirect bilirubin is lipid soluble. So where else are there a whole lot of lipids? Up in your brain. So your brain can take that, and it takes the bilirubin and it will functionally stain those neurons, and it degrades the functioning of the neurons. So once that happens, that cannot be undone. And that process, if it is in high enough amounts that it crosses the blood-brain barrier and goes and stains the neurons, is called kernicterus in a baby. And that's what ends up hurting and killing babies. That's what I hope that none of us in this room ever see. We are trying to prevent kernicterus. And toxic to those brain cells. And it's usually when you're in the 20s, so if you get a lab value back ever and the bilirubin is in the 20s for a baby, you should pucker. The 20s are a no-go for that. This can happen at lower levels, and we'll talk how do you decipher what those are. But that would be the thing that we are trying to prevent is kernicterus. So what does that functionally look like, right? I can talk about lab values all day, but what is a baby with kernicterus, besides looking yellow, going to look like? So this baby is going to come in looking kind of septic. So sepsis and early kernicterus look very similar. Hypotonic. I'm not waking up to feed. Pretty lethargic. I'm throwing up. So all of the same signs of emesis, or the same signs of sepsis. The difference, and the way that I've seen every single board question ask this, is baby was born at home. So home birth, telling you they didn't get some of that routine care. Oh, yes, I remember this was one of those routine cares we were supposed to get at 24 hours. So if I'm already told that there's a home birth, I didn't get that routine care. Then they tell me they're hypotonic, not feeding, emesis, and like, are they septic? Maybe. And then they tell you there's a high-pitched cry. And that high-pitched cry is what's going to help you determine, are they septic, or is this question trying to say that they have kernicterus and it's a bilirubin issue? Because that is a distinguishing factor of kernicterus, is this high-pitched cry. The late signs, that's meaning the brain has been stained, it is toxic to those neurons, the baby is encephalopathic at this point, or when you start seeing that fontanelle that's no longer open, soft, and flat, it is bulging. They have some of this posturing where they are spastic and hypertonic. So that's what the obstetriconic posturing is going to be, is that a picture of that infant. They will have palsy of some of the gazes, so the gazes will change, and you might even see seizures in this child. So that is what I hope none of us in this room ever see, because I need you to be checking them at 24 hours and immediately for every single newborn visit that you see. Okay, that was all of that was the indirect or unconjugated, the lipid soluble type, all of that. Now, this is when it's conjugated. This is when it's directly involved with the liver. So we need to have that water soluble compound added to get it out. So if you see a direct bilirubin above 2 at any point, not normal. You should not have it above 2. I need you to know that number. Remember, if you don't know a number in peds, guess 2. So this one should be easy. Okay? You have a direct bilirubin above 2, something is going wrong. That means the liver worked on it and it can't get out. Something has not happened correctly. Most common, it is biliary atresia. I don't have a biliary tree that is able to take what the liver just conjugated and get it from the liver into the gut. That is what biliary atresia is doing. And if you can't get the compound that makes your poop brown, what color is your poop going to be?
White.
White. And when I say white, the times that I've seen a color stool, it's this. Right? It is white. So people will come in and thinking they have light stools that is concerning for this. I'm talking it has no color. So I always tell people, the only thing that I, as a pediatrician, am camouflaged from in this uniform is baby poop. Okay? So baby poop can be any of these colors. It can be brown, it can be green, it can be light, it can be yellow, it can be all of these colors. Why am I losing this? What is happening? Sorry, y'all. So anything on this, totally fine to be baby poop. The colors I don't want white. That's telling me something's wrong with the biliary tree. I don't want red. There's some sort of blood somewhere. And black, I guess, for digested blood. But all the other colors, totally fine with. I've seen blue poop twice. One time, they ate blueberries all day, every day. And one time, they ate a crayon. So blue poop even is fine in my book. Totally fine. We don't want white, black, or red. Everything else, we're good to go. So it doesn't matter. If they call you and they're like, but their stools are green, that's fine. But they're dark brown, they're yellow, totally fine. If it is on your uniform, you're good to go. Other things that it could be, something is wrong with the liver. So something, cholestasis, a hepatitis, an infection of some sort, something is wrong with the liver, and the liver itself is not able to conjugate this correctly. So you could have any kind of infection that is going to involve the liver, or you could have liver pathology like cystic fibrosis. Most common, and what I want you to put in your heads, is biliary atresia though. That's the most concerning thing that we have. What are my labs that I'm going to do? Well, I want to see if the liver is functioning. I'm going to get my LFTs. I'm going to see if this is an infection that's involved, so bacterial and viral cultures. And then why am I going to get a sweat chloride test? What is that testing for? Cystic fibrosis, correct. My imaging is going to be a liver ultrasound. Why am I doing a liver ultrasound?
If the liver is the concern.
The liver is the concern. What am I looking for on a liver ultrasound? An obstruction could be one. What else?
If there is a liver?
If there is a liver, sure. If there's something else.
The gallbladder?
Gallbladder, but what do I care more than the gallbladder? The biliary tree. So on that liver ultrasound, is there a biliary tree there that would be able to move that conjugated bilirubin into that? They are going to be unresponsive to treatment if they truly have a direct bilirubin, because the way that the phototherapy works, we'll talk about that in a minute, it doesn't work. And an exchange transfusion, we'll talk about what that is in a minute, that doesn't work either, because the same thing is going to continue to happen over and over. So when I want you to think about this for both types of physiologic versus pathologic, it's patterns that you're looking for. So there's an absolute number, but most of the time it's patterns. So for that physiologic jaundice, for most babies, it's going to be high, higher than us, but still relatively lower, in the 5 to 6 range. For whatever reason, I do not understand why, the jaundice that you see starts at the top of the head and it works its way down. And the more jaundice they have, the higher the number. So for me, when I see jaundice that's right at the nipple line, that's about 10. So just from years of doing this, that's about 10. Don't take that, still get the labs, but just roughly, it's about 10. It'll usually peak in those first couple of days before the liver has really turned on the enzyme, before they're getting a good feeding established. And it usually will clear pretty quickly. That's the pattern for that physiologic, every baby has this type of jaundice. That pathologic one, it's really high, it's really fast, as in those first 24 hours, so more than 8 in 24 hours, not normal. Visible jaundice in those first 24 hours, not normal. And then there's usually something else accompanying with it. They are sick, there is some hepatosplenomegaly, there's some anemia, there's some other lab abnormality going on. Okay, so what are we going to do? So how do you actually know then where you're at? Okay, so if you're the PA, they say you're in charge of this baby. This baby was just born, and I did a check at however many hours. What do you actually do as the provider? So you as the provider are going to look at these charts that are called the nomogram charts. And this chart is really kind of, in some ways, confusing because it's a chart that tells you, based on this number right now, what's the likelihood that a future number is going to be harmful? So the way that you read this is, let's say we're going to do this at the 24-hour mark. So first on your X-axis, you're looking at how old is this baby down to hours. So it's the only class that you will care about the hours of life. And then the Y-axis is your TSB, or your serum bilirubin, your total serum bilirubin. So that's what you're looking at. So let's look at the 24-hour mark on the X-axis. And we go up, and we said that 8 was the magic number. So you can see right at 24 hours, you follow it up at 8. 8 puts you right at the cusp of the high-risk zone. And so that is saying that if you had a serum bilirubin of 8 at 24 hours, you have a high risk of, and within 95% of the next bilirubin being concerning for kernicterus. That would be high enough that you need to do something for that. Okay? So they'll put you in your zones and they'll tell you what to do. Very similar if you have that same thing. This is the exact same chart. It's slightly different, but it's for the transcutaneous one. So if you're getting that skin sample, so you still look at the 24-hour mark. So 24 hours of life, this baby, if you get an 8, that still puts you at that high risk zone. So are you going to pull this chart out every time and if you see your pediatricians running around with a chart? No. What are you going to do in real life? Somebody has made this easy for us, right? So where are you going to do on your actual rotations or in your clinics or in the hospital? You're going to use something called BiliTool. And BiliTool makes it really, really easy once you understand how it's working. So I would say, what date and time was this baby born? You have to know the time because the hours matter. So say this baby was born on this date at this time. So I put May 6th at 8 o'clock. And I'm going to do the 24-hour check, so on May 7th at 8 o'clock, so whatever time it is. And then I'm putting what my sample was. It was 5.5. Doesn't matter how you get it for this. And then I need to put in a couple of other things. How old was this baby, and are there any of those other additional risk factors? Literally push go, and it will tell me this. At 24 hours, at a sample of 5.5 for a 39 or term week infant, doesn't have any other risk factors, this is what you do. The recommendations are what you as the provider do. So if you used a transcutaneous, a TCB, do you need to poke this baby? So the recommendation says no. What the column next to that on the right is the threshold. And this is for you to use your provider brain that you are all developing now. So the provider brain says, well, my threshold would be 9.9. So how close is that 5.5 to the 9.9, right? Not very close. So do I really need to poke this baby? Probably not. If at 24 hours it was 9.8 and you were like, oh, my threshold is 9.9, you're going to use your provider brain to be like, well, maybe I do want to go ahead and get a sample. That was very, very close. Right? So that's where you're using your provider judgment in it. For your phototherapy, we'll talk about that as therapy in a little bit. You have your phototherapy. Do I need to do this? Nope. When would I need to do that? Not till 12.8. Okay. Do I need to send them to the hospital, escalate their care, readmit them back into the neonatal ICU? Nope. Don't need to do that. Wouldn't need to do that until it's 19.4. Do I need to do an exchange transfusion? No. Okay. Same scenario. Baby next door to this baby. Okay. That baby was also 24 hours. They were born at the exact same time. That baby has a level of 9. That baby was 35 weeks old. So it matters what you put into that. So now your recommendations were to say, if I was using that cutaneous bilirubin sample, do I need to get a serum? Yes. Yes, you do. So that will be your next order as the provider. You will go order a serum sample. Do I need to start therapy for this baby?
Yes.
Yes. Yes, I do. Right now, because they are over that threshold. Do I need to send them to the hospital?
Not yet.
Do I need to do an exchange transfusion? No. So that is how you are deciding what your level of care is. And it's all based on that nomogram, but BiliTool has made it easy for us to figure out how to do that. When I say, oh, I moved slides. What we're going to do for treatment, these are the other considerations that I look at. So if a mom comes in and says, I have had 6 babies, all of them have needed therapy for this, I just go ahead and know mentally that I'm probably going to have to do that for this baby. So if siblings needed it, if we know that there's some underlying disease, probably going to be something that will happen for that baby as well. Some general rule of thumb, if that transcutaneous one is high, go ahead and poke the baby. As a reminder, your total is both direct and indirect, and you have to calculate what your indirect one is. Other things to look at is, do I have a CBC that has a high reticulocyte count? The reticulocytes, remember, are the baby RBCs. So is the bone marrow kicking out RBCs prematurely because we have more breakdown? So you can see that with hemolysis. What's the blood type? Do you have that ABO incompatibility? Do you need to check? Are there antibodies? Is the Coombs test positive? Are mom's antibodies attacking baby's blood? And then do I have some other kind of underlying genetic issue that would be causing increased hemolysis? So things to consider as the provider if you have a baby who has that high bilirubin. How are we treating? This is one of the coolest treatments. So after Virginia Apgar and her Apgar scoring, which I think is just incredible, we had another in the 50s, 1958, where this nurse was noticing that if she put babies, she was sneaking babies out of the neonatal ICU and taking them outside, which I just think is funny. And she was like, I think sunlight will do good for the moms and babies. And so she was sneaking them outside, and those babies were doing proportionately better. And so when the docs came around and asked what she was doing, she said that she wasn't doing that. And then eventually they were like, well, this baby has a sunburn, so I think, yes, that you are. But anyway, what they were realizing is that the babies who were exposed to sunlight did better. So what is it actually? Is it actually sunlight? What is happening? Well, it turns out it was the blue light that was the wavelength for blue light was able to take that lipid-soluble compound and turn it into a water-soluble compound that could be excreted through the skin as something called lumirumin and then into the urine as urobilinogen. So you could bypass the whole side of the gut because you got it into that water-soluble compound. And so we started using this blue light therapy. So I'm like, if that's not cool, I don't know what to tell you, because we treat kids with light. Like, that's like lightsaber stuff, right? Like, that's super cool that medicine has figured out how to keep kids from dying with light. Like, super, super neat to me. So, things that will help. I gotta get this mom, if she's wanting to breastfeed only, I gotta get her milk to come in. So do I need to get lactation on board? Do I need to help with pumping? How do we get mom's milk to come in? Do I need to supplement? So that can be helpful as part of your treatment. Do I need to put them outside in the sunlight? That'll help a little bit. And then phototherapy. So do I need to order phototherapy? It comes in all shapes and sizes. This is blue light therapy. This is called a bank of lights. So you'll have 1 bank, 2 banks, 3 banks. They also will have blankets that they will send home. They'll have beds that they send home. There's all kinds of ways that we figured out how to do that. And then an exchange transfusion is one of the coolest things that I've seen. They literally hook up a baby with 2 IVs and 2 giant syringes. One is filled with blood, the other is empty, and they suck blood out one side while they put new blood in the other. And they are literally exchanging the baby's blood real time. So exchange transfusion takes all that lipid soluble out very quickly and gives them new blood. Somebody asked me a couple of semesters ago, well, is anything harmful from phototherapy? And I really couldn't find much. A little bit of diarrhea, which I don't really know why that would be harmful, because we actually want them to stool their bilirubin out. So that would be fine. Yeah, there's some maternal infant bonding if they're having to lay under the blue lights. And then maybe some temperature instability because their skin has to be exposed. Long term, not a whole lot. So they don't have kernicterus, they don't die, and we saved babies with light. So if you take away nothing from that part of the lecture, please, at 24 hours, for the love of God, get a bilirubin sample and do not let kids go home with kernicterus. I think that is that one. Does anyone think that light is as cool as I do? Somebody, more of your outlines, more of all of your individual objectives. Okay, so why do we put all of these topics together, these growth and development? Well, for a couple of things. Ton of pediatrics is preventive medicine. So if you look at your PANTS, PANTS has said that 10% of all topics covered are dealing with health maintenance and health prevention. So when we're in ClinCore and we're like, well, what 2 preventive measures What does the US Task Force say? It's because 10% of what you're going to be tested on is dealing with health maintenance. So a ton of that falls under some of the pediatric categories. So we group a whole bunch of that, or I group a whole bunch of that together for that reason. There's also increments where visits are recommended / required / reimbursed from insurance. So how many of you have had a comprehensive wellness exam in the last year? 0 hands. That's incredible. Nobody's hand. How many well visits occur in pediatrics in your first year of life? A lot. How many?
12?
Not 12.
6?
7.
7.
7 times kids come and get this comprehensive exam. So 7 in the first year, 10 in the first 2 years, right? So that's a lot different. That's a lot different than when you think about adolescent medicine, adult medicine, even geriatric medicine. We're seeing a patient 7 times just for well visits in their first year of life. So that makes it a just different part of medicine. So things that we're always going to look at, is this child growing? I need them to grow. I need them to go from I fit inside of mom to the functional size that all of us are as adults. I need to make sure they are developing. So I might have normal growth, but I don't have development. Or I could have normal development, which are the size of a mouse. So you can have things that go awry in just one area or another. We're going to do preventive screenings, so we're going to talk about all of these individually, but preventive screenings, meaning I'm going to do this for every single child out there at specific time periods, your immunizations, and then all of the guidance that we're going to do that is age specific. I'll tell you my traumatic story then. So back to our terms. So we already covered our neonates. You guys got those down. We're starting functionally really with our infants and working our way up, but I need to add a couple of terms. So when we are talking about growth and development, you will hear people put those terms together. You say, growth and development. Growth is taking your actual physical body like a transformer. So the growth where they are transforming right in front of us versus the functionality of that. So you can have growth with 0 development, or you can have development and no growth. So you have to analyze these 2 things separately. So we'll start with growth, but those are not interchangeable when we are using those terms. So when we're talking about growth charts and how we measure those, we are doing those with our standard, both WHO, World Health Organization, and the CDC growth charts. We're looking at development through a couple of things. So we'll teach you how to use a couple of those. Ages and Stages Questionnaire, or ASQ. And then what the military has switched to is called the SWIC, the Survey of Well-Being of Young Children. It's like the worst acronym ever. Like not even, doesn't roll off the tongue at all. And then developmental milestones. So these are things that as you become a more seasoned provider, these are those things that you can check to spot a mile away, right? So you guys do this all the time now, right? When a new class comes, you guys are the senior class now, so you can look around and you see OC on a uniform and wide eyes and people that look scared to death, and you're like, that's a freshman, right? That is what developmental milestones are, is when you can walk in a room and you're like, that's not normal, or that is normal, based on how somebody is presenting developmentally to you. So what are the things about all of those 3 facets that we're talking about? Well, growth charts. So the pros of that are that it's super reproducible. If you guys had if your mom kept a detailed, or dad kept a detailed record of how much you were at each age, I could make your growth charts right now. So they're reproducible. Pretty easy to do. It doesn't take a whole lot of training. However, it's operator dependent. So when you will see that your techs or MAs or medics or whoever you're going to be working with, especially in pediatrics, sometimes they will put pounds in instead of kilograms. They will put inches instead of centimeters. And so all of a sudden your growth chart looks way off. So the number one thing, if you see a growth chart that doesn't make sense, it's going to be operator error. Your screening. Parents are actually really good at talking about their children's development. So it's pretty accurate and it's reproducible. You ask mom if this kid can do this, and you ask her again in a couple of days, she's going to likely give you the same response. However, if any of you have gone to a pediatric clinic and you have done the intake forms and they're 17 pages long and it takes you 27 minutes to fill out, very time consuming to get some of that data. And then your developmental milestones. Again, it becomes fast and easy, but it takes a little bit of expertise. It takes a little bit of doing this for a while to say, well, that's normal or that's not normal. Okay, so these growth charts. So from the age of birth to 2, because everything is in 2 for pediatrics, we are going to use the World Health Organization data. So the chart is put together by the CDC, but the data is from the World Health Organization. So you'll always say, yes, we're going to use the WHO charts. And we use the World Health Organization charts because most of the rest of the world breastfeeds a whole lot more than we do in the United States. So we have compiled the data from worldwide data. For the older kids, 2 all the way up to 20, we use the data from the United States, specifically with the CDC, where breastfeeding not as much of a factor. Links to those, but we're going to look at them like this. So the charts are either blue or pink. So blue for the boys, pink for the girls. You know which chart you are at based on the top. So it'll say birth to 2 or birth to 24 months old. And then it will tell you there's 4 different parts. So this is one set. So this is not 2 of the same things. This is for one age. So you have 1 for weight, 1 for length, 1 for head circumference, and 1 for your proportionality between weight and length. So you might have a baby who's normal for length and normal for weight, but they're not proportional. Right? They're a squatty little thing or they're a stringy little thing. Okay? So you can see different proportionalities. So this is one set of charts. You switch over now above 2. So now you have 2 to 20. This is a little girls chart. And it makes sense that you're seeing this chart where you are seeing the period of rapid growth. So back to the 0 to 2, when you're looking at it accelerates pretty fast in those first few months, 0 to about 9, 10, and then it starts to slow down. You see that same thing that will happen right around puberty. So 9, 10, 11, 12, those charts get steeper because there's a rapid acceleration of growth, and it levels out once these girls are done growing. So the chart should make sense. So if you're like, wow, this doesn't make sense, are you in the right chart when you're doing that? Some of the growth patterns in the first year of life then. So I expect every baby to lose weight. Why do babies lose weight? Every single baby that comes out of mom, they were getting 24-hour glucose and they were just sitting there living life. It was pretty good. They come out of mom, suddenly they don't have those 24-hour continuous glucose infusions. So I expect every baby to lose a little bit of weight, down to 10% of their body weight. Right? So if you have a baby, they come in and they give you a weight, your tech, your medic, whoever gives you a weight that is below what their birth weight was, normal. If you calculate that down and they've lost 12, 13, 14% of their weight, not normal, and we need to intervene right then. So circle that 10%, don't let them go below 10. They should, in the next 2 weeks of life, figure out how to go from, oh, I was in utero, I have lost weight, and now I am back up to a normal weight. So they should regain their birth weight at least. Some of them are overachievers and they just keep on going, or mom makes whole milk, I guess, or heavy cream, but they should be back to normal, their birth weight at their 2-week well visit. So you get 2 weeks to regain your weight. You should double your weight by the time you're about 4 months old, and you'll triple your weight by about a year. So if you were a 10-pound baby, you're probably going to be about 30 pounds at your first year of life. If you were 5 pounds when you were born, you might be closer to 15 pounds. Your daily weight gain. This is where we'll use kind of some, not guesstimations, but this is why it's helpful to bring babies back for close interval follow-ups, because if you have a baby who hasn't gained any weight, and I know that this baby in those first couple of months is going to gain 20 to 30 grams a day, and that's about 1 ounce a day. If I said, I need you to come back in 1 week, I would expect that that baby has gained 7 ounces, at least. If they're not gaining that, and I'm a little worried about that. So you can bring babies in, come back tomorrow, come back in 2 days, come back in 3 days, and you can very quickly see how much they're gaining. So about 1 ounce a day in those first couple of months until they double their weight and then about a half an ounce a day after that, up through that first year. So please be able to calculate that. They tell you this is how old this baby is, this is how much should they be gaining, what's appropriate weight gain for this baby. Because you would be, as a provider, figuring out, is this appropriate or is this too little too much? Similar in length and height, so babies come in really flexed, and so I don't expect for them to be, length is not as helpful to me as long as they are continuing to lengthen. So most of them will start at about 50 centimeters, give or take, so about 20 inches is average, and they'll get into about 30 inches in that first year of life. Typically by the age of 4, they've doubled what their length is. Head circumference about 35 centimeters to start, and it's going to go by about 1 per month in those first year of life. So the head is going to be the most rapid thing that grows. Again, we're watching for macrocephaly to make sure that it is not too much. We see rapid growth in those first 9 to 12 months. What happens around 9 to 12 months that's going to cause this to slow down? What happens to a baby around 9-10 months? What do they start doing?
Walking.
They're crawling or walking. They're mobile. So for the first time, they go from being a little cockroach that's just laying there, consuming calories, to now they're actually expending calories. And so the growth slows down, the rate of growth slows down because they're expending more calories because they're moving. When it shifts, so they might have always been in a certain percentile, and we'll look at some of those, they might have always been in that, and suddenly they start to be mobile, and that shifts into a different percentile. If you ever hear the word channeling, that's what channeling is. Head circumferences, again, that's one of the most crucial ones that we're looking at because that's brain growth and brain development. So we're always looking at that. The other thing that we're looking at once they get above the age of 2 is their proportionality. So we're looking at body mass index. We all know that body mass index is not the perfect measurement, but it gives us a generality when we're looking at patterns of pediatric growth to say, ooh, you're on the right, you're projected appropriately, or there's some concern, and we're looking for what do we need to do to change some of those patterns. So if we're looking at percentiles, and percentiles again, meaning you line up 100 normal, where do you fall? Are you number 1? Are you number 100? Somewhere in the middle. Not percentages, percentiles. If you are less than the 5th percentile for BMI, that's considered underweight. Doesn't mean bad, wrong, it just means as a provider, I need to make sure that I either have a reason, maybe all the family's small, or I've evaluated, or I know what's going on, or this has always been their pattern. If they're in the 5th to the 85th percentile, normal. 85th to the 95th is considered overweight, and then 95th and above is considered obese. And those are separate things that you can code for and have for billing. It is a separate diagnosis to put in and calculate a child's BMI. It's right at the 50 mark. So take your break, and then we'll come back at top of the hour. Last hour, just to see, proof of life. What is that level of pathologic jaundice that I would expect to not see in 24 hours? What was that number?
8.
8. What was it for direct bilirubin? 2. Correct. Which type of jaundice has an inhibitor of bilirubin conjugation? Breast milk jaundice or breastfeeding jaundice?
Feeding.
Breast milk jaundice.
Correct.
So the milk is the issue, correct.
Yep.
If you have an elevated level of that direct hyperbilirubin, what kind of imaging do you need to get? Liver ultrasound. What are you looking for? Biliary trait, correct. And then what is your standard treatment for hyperbilirubinemia? Run-of-the-mill yellow baby. Phototherapy or blue light, correct. Because we treat kids, we save kids with light. So, okay, you guys are good. Proof of life, check. Yes, ma'am.
Is there something that predisposes you to that inhibitor in the milk?
That's a great question. I will look that up. I don't know. Inhibitor of milk, what causes that? I don't know. Good question. Okay, so we are back talking about kids' growth and how we're looking at that. So back to height. So one of the things parents will often ask you is how tall do you think this kid's going to be? So the most accurate way, and what you guys learned in radiology, is if we're trying to do accurate prediction of height, we need to do a bone age, where we're taking a one shot of the left hand, and a bunch of radiologists will sit there and look at what it's closest to be able to predict a height. Super scientific. It really is. It's with growth plates. Are we going to radiate children just to see how tall we might think they're going to be? No. So not very often done unless there is a concern or there's a problem. So there's a kind of a predictive factor that we'll do. So we'll say mom's height plus dad's height, divide that by 2, add 2.5 inches for a boy, subtract 2.5 inches for a girl. Within about 2 inches, it's going to give you a rough guesstimate. The other thing is, because it's pediatrics, the rule of 2s. So at 2 years old, double your height, that's probably your adult height. Double it at 2. When you think about that, you're like, what? 2 is pretty tall. So that's going to be the first thing. Every single specialty will tell you that they have a 5th vital sign. So they'll be like, in women's health, they'll be like, your last menstrual period is your 5th vital sign. And in surgery, it'll be like pain, and the peds have one too. And it's your growth charts. So growth charts are going to be part of each and every visit. The reason that I say that is because growth is a luxury of nutrition. If you don't have extra nutrition, you will not grow. Something is wrong. So growth is a luxury of that. So if you do not, and if you are noticing something that is wrong from any kind of growth perspective, something is not right, and you need to look further into it, just like if your blood pressure was wrong, if the temperature was wrong. So growth charts become quote-unquote vital signs in peds for that reason. So start looking at nutrition. So calorie intake, is it adequate? So how many times a day are they feeding this child? How much? Are they doing formula or breastfeeding? What's going on? So the story I always tell, lovely, very, very young parents. I believe they were 18, 19, maybe 19, 20. Very, very young parents. And they came away from family. We were all active duty, stationed wherever. And this baby just was not gaining weight. Babies aren't supposed to lose weight after that first little bit of life. So this baby was just not gaining any weight and starting to lose weight. And the parents were like, yes, we are feeding them. This is how we're feeding. This is exactly what we were doing. So finally I sat down with them. I was like, walk me through a day. They said, we were feeding the baby breakfast, lunch, and dinner, right? And they were feeding this baby 3 times a day instead of every 2 to 3 hours. And so they were doing exactly what they thought was correct, and it wasn't enough for this baby's physiology, right? So sometimes in our history taking, we as providers don't do a good job of asking what we mean, and they're telling us truly what they think that we're all on the same page and we're not. So number of feeds, how many in 24 hours? How are you preparing the formula? How much water to formula ratio? So sometimes people will try to thin out the formula to have it last longer. Maybe there's actually not milk transfers so mom's breastfeeding for 45 minutes, but baby's unable because of a lip tie or a tongue tie, ankylosing, can't actually transfer any milk. And so the baby's just using calories doing that. Is there some sort of chronic illness in the family? What kind of family history is there? Because ultimately that's often the case, that genetics is going to be the most likely cause of some sort of small or large child. So when you see these families, some of the time I've had families where dad's 5'4", mom's 4'9", and they're like, do you think he'll play in the NBA? And you're like, probably not, but you never know, right? So there are some times where, and you really have to help people meet their most likely expectations. Things when I think about chronic disease. So you rarely, if ever, there is one exception we will talk about in the genetic disorders, but rarely, if ever, is chronic disease going to make a larger than normal child. Chronic disease is going to take away nutrients, and so often those children are going to be much smaller. So something to think about for children with chronic illness. When do I consider action? Well, we said under that 5th percentile for weight was one of the things that I look at. So why aren't you gaining weight? The other thing is to say, have you crossed 2 percentile lines? And we'll look at what that means on some growth charts. If you have crossed 2 percentile lines, in the time period from that last well visit or at any point in time, and I don't have an explanation why, I need to look at that. So either increase or decrease, and then if there's a large discrepancy, so maybe I'm gaining weight but my head's not growing. So something where something isn't matching like that. Things to look at also, was this baby premature? Were they small for gestational age when you're doing a chart review for history? For growth, they have 6 months to catch up from however much they were born. For development, it's 2 years. So that's where growth and development are different. So if you were born significantly early, you should be at that size 6 months later, but your development might lag for up to 2 years. We might give you some sort of denser formula. So most formulas, actually all formulas, are 20 kilocalories per ounce. So every ounce they're getting 20 calories. Mom's breast milk, we have no idea what that is. It's around 20. Does this mom make 18 per ounce? Does this mom make 26 per ounce? I don't know. Sometimes I tell them, maybe you make skim milk, maybe you make whole milk, maybe you make half and half. We don't know. There are places where they will analyze mom's milk. TRICARE does not cover that, just of note. Okay, so this is what crossing 2 percentile lines means. So if we're looking down at the bottom on the x-axis of how old this kid is in months, down at the bottom, and we look at where those points are, that is what your percentile is. So that first point, right at that year and a half, is up in between that 25th and the 50th percentile. So we'll guess, and we'll say that's about the 30th percentile. And that next time they come in, that next dot is still within that same channel. It hasn't crossed a line, but now that third one right at 2, it's crossed 1 percentile line. And now not only is the baby losing weight, but by that second one, by that time right at that 28-month mark, we've crossed 2 percentile lines. So at 2 percentile lines, that in no way, shape is normal. By the time we are across that 3rd percentile line, we've crossed 3, and that baby has lost a significant amount of weight. So if you were that provider, where should you have intervened? At how old? Which one? At the 2 mark, right? They haven't crossed 2 percentile lines yet, but they're losing weight. So never supposed to lose weight. And then your second time would have been at that next one where they cross those 2 percentile lines. Not normal. So after they're 2, that rate is going to slow down a lot. So that first 2 years of life, they get about half of their growth. And then from there, you usually remain in the same percentile. So if you, at the age of 2, were in the 95th percentile for your height, you're probably still pretty tall. If you were in the 5th percentile, you're probably still pretty short. So if we're looking at this infant comes in for their 6-month well child check, and your technician brings you these growth charts. Are you concerned about this kid? Yes or no? How many for yes? I have some yes, how many no? No. I am concerned about this one because I have a child who has crossed now 2 percentile lines, and that is never normal. And they are 6 months old. So 2 percentile lines have changed. Your next chart, the 9-month-old here for a well child check, and your technician brings you these charts. Are you concerned about this child? How many for yes? How many for no? Correct. You're not concerned about this child. Why, though, at that 1 for weight, why are we not concerned about that child? This is the 5th percentile, right? Why are we not? Some to do with the height, but they've always been the 5th percentile. So they have an established pattern of showing you that I'm continuing to gain weight. I'm just in the 5th percentile, and that is where I am. So I care much more, and all pediatricians and providers will care so much more about the patterns over time than one snapshot in time. Okay, so that's why keeping these growth charts and looking at them every single visit are super important. That takes us to some nutrition. So in these first 3 years of life, this is when these health outcomes are really kind of developed. So we said there's half of their growth is going to be by the time they're 2, but really so much of what kids' adult lives are going to be like is determined in those first 3 years. So if I see a child who is significantly obese in those first toddler years, very concerning. If I see a child who's emaciated and is not growing correctly in those first couple of years, very concerning. Nutrition is a luxury of growth. The specific window of time for growth and weight gain that I'm very concerned about is that 4 months to 24 months. So functionally, 2 months to 2 years. So just go with the 2s. So that's the time when there's growth stunting that occurs where you can't catch up some of that growth. So if they're under a year, a couple of things. So the American Academy of Pediatrics recommends breastfeeding as your sole nutrition source if possible for at least 6 months. Now that's what the AAP says. What I usually say as a provider, this is me, I will say fed is best. I don't care how you feed your child, just feed them. Okay? I did residency over here at BAMC, so they used to have this big sign. So mom would be on the labor deck, and then they'd go over to the mother-baby unit, and on the way in was this gigantic sign that said breast milk is love turned into food. And I was like, take this sign down, because then moms who just couldn't breastfeed or didn't want to were just like in tears and like, I don't love my baby. And I was like, this is the saddest thing ever. Like, take this down. Fed is best. Okay, so AAP recommends breastfeeding, but fed is best. Love turned into food. Anyway, but it makes sense that it is recommended because there's so many things in breast milk that formula can't offer. Immunity being the main source of that. So a full spectrum of IgG antibodies that are going to help with all the things. So one of the things we talked about yesterday was human milk is helpful and protective against that necrotizing enterocolitis, or NEC. It's going to be one of the reasons we see that is the passive immunity that mom will get. So pick an infection, any infection, diarrhea, respiratory, otitis media, all of those are going to be significantly decreased with that passive immunity. Also in preterm infants, they will give human milk, if at all possible. It will have a long-term higher IQ by about 5 points. So I'll take 5 points here or there. But feeding is not for the weak. So it is not the breakfast, lunch, and dinner, the 3 times a day. Feeding should be occurring every 8 to 12 times a day, every 2 to 3 hours. Reason being that liver that just isn't mature yet, doesn't have an awesome storage for gluconeogenesis and all the things you learned from biochem. So they aren't able to keep their glucose up in those first couple of months. So they need frequent feedings and a little bolus of sugar. We say every 2 to 3 hours. For those of you who have been around an infant, that's real cute. And they say every 2 hours, sleep when the baby sleeps, right? And you're like, well, So it takes 30 minutes to feed this baby, because they take forever, and a whole bunch of time, and then they poop and you have to change them. And then you gotta try to get them down and burp them, and then they throw up, and then it starts all over again, right? So you got maybe 45 minutes in between. Sleep when they sleep. So when you're telling a parent that, just make sure you're very conscious of what you're asking them to do. How are you then, as the provider, assessing their hydration status? So this would be one of the times where, I'm sorry, it's 2 times 2, but it's still a derivative of 2. A child needs to have 4 wet diapers a day to be considered, to say, and they have normal kidneys, that is appropriate hydration, at least. That's the minimum. So typically a family will say there's about 6 to 8 wet diapers a day, but I need at least 4. The caveat is you have to take a good history. I have some families that say whenever we feed, we change the diaper no matter what. Okay. I have other families, and that baby is like dragging a full diaper around until it has gotten every last use of it. And so they're like, we only change the diaper 3 times a day. And however they do that. So make sure you understand that it's saturated diapers, 4 saturated diapers. Stools, we said, it could be anything. So stools, anything on this uniform, any of those colors. Typically breastfed infants, if you've never seen breast milk stools, it looks like mustard with sesame seeds in them. It's a very specific looking breast milk stool pattern. You're like, where did these little seeds come from? There's nothing in the breast milk, and that is just the way that breast milk stools look. It will change when they start solid food, so typically about 4 to 6 months. There really is no specific amount that they need to stool or not, so it's quite fascinating. Parents will get very upset that the baby has not pooped in a couple of days, but they are very young, and they come in for their well visits later, and the kid will be like, I haven't pooped in 2 weeks. And the mom's like, really? They have no idea. So you see both sides. When you're thinking breast and bottle feeding in those first couple of months, just a pro and con list. I've seen a pants style question exactly on this, which was fascinating to me. So pros of breastfeeding, you get that passive immunity, so that's the biggest thing. There's that bonding, and it is technically considered free, so free monetarily, but a lot of timing. It does take that time. It's pretty low in vitamin D and pretty low in iron, also pretty low in vitamin K, so really all the fat-soluble vitamins. And then there's that breast milk or breastfeeding jaundice that's always possible as that. Pros of your formula, pretty easy to prepare. You know that they are getting nutrition that is adequate. It's 20 kcal per kilo. And they get some rapid weight gain. So you can make some fat little babies with formula if you want. If you've ever gone down the aisle at Target for baby formulas, it is expensive. So formula, very, very expensive. No immunity. And a lot of times when families are like, well, we made 4 ounces, so this baby's going to drink 4 ounces of formula. So sometimes there's an increased risk of obesity. We'll talk about some of those. Who can't breastfeed? This is always one. Let's start this slide. Who can't breastfeed? So the recommendations have changed on this one. So we used to say moms that have HIV cannot breastfeed. Then it was changed to moms in industrial countries only shouldn't breastfeed. And they changed it in May of 2024. And so now there is a specific shared decision making and a specific viral load that a mom needs to be under to safely breastfeed. So it's still shared decision making, but for our purposes, be very cautious with a mother who has HIV. Yes, sir.
Can you boil the breast milk? I heard that denatures it.
That's going to denature, so you lose that passive. Yeah. So you can boil it, but you lose the immunoglobulin. So. Active TB. So this is not latent TB. This is specifically active TB. And then varicella, the first couple of days of influenza, and then herpes. So both varicella and herpes are if there's actual lesions on the breast that would expose the child. Alcohol, so you've probably heard of pump and dump, where a mom will pump after she has had a drink and dump that breast milk. There was a little bit for a while where they would say, find the baby, feed the baby, which I thought was fascinating. It's like, as long as you can find the baby, and you can feed the baby, that kind of moved away from that a little bit, for obvious reasons. Other things to think about is if there is a radioactive compound. So what could you think of that might be something like that? Some thyroids and things where there's iodine involved, things like that. If you had chemotherapy or these anti-neoplastic immunosuppressive drugs, so if you are on a specific inhibitor, like methotrexate, high dose of steroids, and then obviously any kind of illicit drugs, we wouldn't want mom to be passing that along. So know this list. How about infant contraindications? You think, well, every baby should be able to breastfeed, right? Not necessarily. There's one true contraindication. This baby absolutely cannot breastfeed, and that is a baby that has galactosemia. So a baby with galactosemia does not have the ability to break down galactose. Remember from, gosh, what was that, freshman biology? What is galactose made up of? Glucose, lactose, right? So you have galactose, you can't break it, or sorry, lactose is made of glucose and galactose. You cannot break that down, and that buildup is going to be a harmful compound that you will die. So galactosemia is no-go for breastfeeding. That is the only true contraindication for children to breastfeed. How are you going to feed those babies then? What do they get? I heard it over here. What kind of formula? Lactose-free formula. What kind of formula is that? Soy-based formula. Yep. So this would be your only true indication for a soy-based formula is galactosemia. With phenylketonuria, they can have some phenylalanine, just a limited amount, and so there are low phenylalanine formulas, and you can write a script for a low phenylalanine formula that TRICARE covers. What's not a contraindication then? So this is actually really more often the way that I see this question worded for PANCE prep, is what is not a contraindication? So can mom still breastfeed if she has mastitis?
Yes.
Yes. Why is that? It's because mastitis is functionally cellulitis of the breast. It's not an infection of the milk duct. Okay, so it's uncomfortable for mom, but it is not contraindicated. It actually will sometimes help move things through. So nursing as tolerated. The other one that is not a contraindication is methadone. So as long as you don't have any other illicit drugs with that, okay to breastfeed while on methadone. There's a lot of formulas out there. If you have nothing better to do on a Friday night, go look at the formula aisle at Target. There's a million different ones. What do I say as a provider? If parents are like, well, what should we get? I say start with the cheapest one and work your way down if you need it. So Similac, Enfamil, there's a million different ones. All of the basic formulas are going to be a whey protein, 20 kcal per ounce, or a casein protein as well. They all will have iron in them, so standard formulas. The soy-based ones, really the only time that you are going to specifically say that has to be that is galactosemia. If they say, well, we had trouble with cow's milk formulas and milk proteins are an issue, you're still at 30% cross-reactivity. So if it's working, I don't touch it, but it's not what I recommend. And then you have some hydrolyzed formula. What does that mean? It means that it's already been partially broken down before it gets to the baby. So it's easier for baby to digest. It moves through faster, so they have less emesis, less discomfort, easier to digest. So my go-to for that is Nutramigen. It's my first one. Alimentum is a fully hydrolyzed formula, meaning it is down into its amino acid. It's just it's like liquid amino acids, and it smells disgusting. So if you've ever had to give your child Alimentum, you're like, why does it smell so bad? It's because it's just straight amino acids liquefied. Very expensive. But if medically indicated, TRICARE does cover all of these. So basically, if you're looking at this and you want to study this slide instead, it will say, don't give them things they can't have. Please feed your baby, and we'll start at 4 to 6 months with solid foods. What are we going to supplement kids with? When do we give them iron? We said all babies are going to lose some of their hemoglobin, so who do we give this iron to? Well, I want to give them to preterm infants. So that's my number one category. If you didn't get all of the stores that you should have had and you were more than preterm, and how are we defining that for our purposes? Less than how many weeks?
38,
37.
37.
Less than 37 weeks. You're preterm, or if you are going to exclusively be breastfed after 6 months. That's not the recommendation, but some families will choose that. It's then recommended to add iron to that. I don't need you to know this particular dose. You will learn that. But you will start that over the age of 6 months if they meet that criteria. And then it's in the formula. So formula doesn't need any other iron fortification, usually unless you're premature. The other one that you are going to need is vitamin D. So it's another one of those fat-soluble vitamins. So we said A, D, E, and K. So we already gave K as a shot. Now we're giving vitamin D as an oral supplement. You will need this dose, so 400 IU a day, international units a day. It's not conferred very well in formula, and it doesn't pass through the breast milk particularly well. Even older kids, so after they're a year and they've been on 400 IU, they need to switch up to a higher dose of 600 IU. You can prescribe this to families. I will tell you that I don't know what kind of distributor that TRICARE found somewhere, and they gave the most disgusting smelling vitamin D that you could possibly get. And it's like a large amount. So you give a whole meal of vitamin D and it smells disgusting, and the babies, like, you want to see like a baby kind of like retch, like give them that. Or you could say you can go to Walmart and get a bottle of that where they get 1 drop a day, and it's lovely for everyone. So up to you. So you can prescribe it, but that's what you're getting from TRICARE, just letting you know. That one's free. What if we don't have that? We're always worried about a vitamin D deficiency with rickets. And this sounds weird, that you would be like, really? Rickets in the military? But yes, you go and you see it in a couple of places. I've seen it in a couple of different settings. Number one, up in Alaska, where they don't have a whole lot of sunlight, and then they're not doing that. Or places where there's so much sunlight that they're not taking the babies outside. So places like Arizona, where it's so hot that they don't take them outside and don't actually get any sunlight. So what do we see in those babies? Well, you can get thinning of the skull. And so craniotabes is what that is called, where the skull itself is so thin that it can very, very easily kind of cave in from not much pressure. Thickening of your wrists and ankles, and so right around those growth plates you see very, very thick on exam and on radiograph. The rachetic rosary is a picture of the baby at the bottom, where you can see right at that costochondral junction, you're seeing that thickening right at that junction area. That's what a rachetic rosary is looking at. And then a delayed closure and a very, very large anterior fontanelle. So remember, about more than finger breadth. What was the other cause where you had a persistently large anterior fontanelle? Nobody remembers. So what do you guess? Hypothyroidism. Yes. Hypothyroidism. Yep. I'm telling you, when in doubt, and you're like, I don't know, say 2. And hypothyroidism, and you're going to be right the majority of the time. And then your classic bow leg, right? So you know that one. So the bigger ones are for the little babies who aren't getting this supplement. Obviously, your history is going to have, do they go outside? Did they get any sunlight? Did they get any vitamin D? Your plain films are going to be how you're going to look at this. Certainly replace what's missing. So replace your vitamin D. The biggest thing on this that I've seen parents ask is, can you identify that this is a vitamin D deficiency on physical exam for a child? No honey. Why can't we have honey? Botulism. We just say botulism. What's wrong with botulism? What does Clostridium botulinum produce?
It's like a
toxin. Yep. What does that toxin do? Paralyzes you in contraction or relaxation?
Contraction.
Relaxation. What's the one that does it for contraction? Tetanus. So Clostridium tetani and Clostridium botulinum are exact opposite of each other. They both paralyze you. One's in contraction, one's in relaxation. So no honey. We'll avoid that one. Really, the child's gut can probably handle it at about 9 months, but we are safe up to 12. The solid foods. There's a big controversy in pediatrics. Dun, dun, dun. At 4 months old is when we start talking about when do we want to introduce solids. Some kids are ready at 4 months old. If you can sit up, you can hold your head up, you are ready to start solids if you're starting to show some of those mouth movements. If at 4 months old you are still like sinking down and like trying to fall over, probably not developmentally ready. So everyone agrees after 6 months you should be doing solid foods. Everyone agrees under 4 months we should be doing breastfeeding or formula feeding only. 0 people agree what to do between 4 and 6 months. So you as the provider will have to use your provider brain with the parents to say, when are we going to start this and how are we going to do it? There's no right order. So some people will be very draconian about the baby stages. I do stage 1, then stage 2, then stage 3. Some people will say I do baby-led weaning. Some people will have a certain order they're going to do. Doesn't matter. As long as you are feeding the baby in some sort of order and watching for reactions, you are good to go. Up until they're a year, solid food is complementary, so we're doing it to give them texture, give them taste, give them exposure to the antigens, but it is not their primary source of nutrition until they are a year. So the calories and their main caloric source is still coming from breast milk or formula. All pediatricians really hate juice, so don't pick that. It's not going to be the right answer of give the child juice, unless it's block 2 and we're talking about constipation. Okay? It's the only time. Don't pick juice the rest of the time. Also, don't substitute formulas. I had a practice question recently that had a family that lived on a farm and they substituted goat milk for formula, and the child came in with a macrocytic anemia. And it's that goat's milk inhibits folate absorption. And so they end up with a macrocytic anemia from goat's milk when they're replacing. So when we're saying don't replace these, it's because there is something downstream that the child is not going to be getting that has some harmful effects. So cow's milk, very hard to digest that protein in a young stomach, and it can have some GI bleeding. And again, the goat's milk was just a recent one that I have seen. Other things that we want children exposed to in that first year of life, I want them exposed to some sort of dairy, to an egg, to soy, wheat, tree nuts, peanuts, and shellfish. So when I started residency, I think you had to have a driver's license before you were allowed to eat peanuts. Kids was don't give them peanuts. And the pendulum swung the complete opposite direction. And now we're would you like some peanuts after your delivery? And really, because when we were pushing it off so long, the children are not being exposed to this antigen, and then they were sensitized and having anaphylactic reactions to peanuts. And so there's this whole generation of kids that can't have peanut butter and jelly sandwiches. It's so sad. But the LEAP trial came out, and I don't need you to know the LEAP trial, but what it basically said is these children need early exposure to these antigens so that their immunologic system is not hypersensitized to this. So now we want to do early introduction of all of these hyperallergenic foods. The things that children have problems with, we want early introduction to that. So particularly for peanuts, the one caveat would be if a child presents with really, really early atopic dermatitis or eczema. The correlative factor is higher there. So if you have severe eczema, then you're going to want to make sure a specialist is on board for when you're introducing peanuts. So if it's mild, moderate, we still will do it. We'll have them bring peanut butter to a well visit, and we'll give it to them during the well visit so that we are in a controlled reaction to see any kind of reaction. If they have severe eczema, they will be doing that in the allergy clinic where they can have a further follow-up. So this is just FYI. I'm not going to test you on this. Point being, severe eczema, specialist before peanut butter. Everybody else, all those hyperallergenic foods within that first year of life. What about once you're over that year of life? Well, once you hit that 12-month mark, we've said, and it's 9 months, but 12-month mark is where we've said, now you can switch over to the cow's milk for a good source of calories. We usually say whole milk. Your brain grows and functions on fats. So we want the kid to have lots of good, healthy fats. So we don't want it limited. That's why we want whole milk until they're 2. And after that, if there are some obesity risks, then we can go down a little bit. We do want to limit the intake to 16 to 24 ounces. And if you think about how much that is an 8-ounce glass of milk for a 1-year-old 3 times a day. That's a lot of milk. Okay? I had a family once that they literally bought a Costco membership because the kid was drinking 7 or 8 gallons of milk a week. Because all this kid was taking was milk. And they were incredibly anemic because there's no iron in milk. Right? So you have to limit milk intake somewhat, and don't buy a Costco membership just to feed your kid milk. The other thing we want to make sure that kids are avoiding appropriately is foods in a form that could cause a choking hazard. So it doesn't mean you avoid the food, it means you avoid the food in the form that could cause choking. So I am not saying from this, do not feed your children grapes. We'll cut the grapes in half. Do not feed them hot dogs, just cut it in half. Cut it so that it's not going to lodge directly into the esophagus or trachea. Still limit juice, so while the AAP has said, okay, fine, you can have a little bit, we are going to limit it. to a small glass, 4 ounces for the little guys, 8 ounces at max for the older ones. But we will use it sometimes as constipation. We're not limiting fat intake as well, and we don't ever want to put a child on a diet, especially before the age of 3. We want those good fats. We want to maintain, if nothing else, and let them grow into whatever weight they have put on. So most of the time, those discussions are about a family lifestyle, an activity, food choices, knowing that there's some complexity there with families' choices. Okay, so short-term memory. At what age can honey be given safely?
1 year.
1 year, yep. And then there's going to be a pattern here. At what age do we do head circumference up until? 2. How many percentiles on the growth chart should raise concern? 2. At what age do we switch from the WHO growth charts to the CDC growth charts? 2. You're getting the point? This is a piece. Guess 2, guess hypothyroidism. And that one's fun. Questions, comments, concerns, anxieties, frustrations, miscellaneous toxicities? I think I've looked at your nephro test. It's not that bad. Okay, so it is hard, but like I think Colonel Gendron like scared you for it's the same that people passed last semester. So you guys are going to be just fine. Everything's okay. So study well, but you're okay.